Hello and welcome. It is a great honor to introduce our next speaker, Dr. Gianoli. Dr. Gianoli graduated from Tulane University with a degree in engineering and medical school in 1986. He did an internship in general surgery and an internship in pediatrics, following a residency in otolaryngology head and neck surgery. He completed his fellowship in otology, neurotology, and skull-base surgery at the Michigan Ear Institute. Dr. Gianoli is one of less than 200 board-certified neurotologists in the country. He still maintains a clinical associate professor appointment at Tulane. Dr. Gianoli has been consistently named to the ranks of America's top doctors and America's top physicians. He has published and lectured extensively in the field of neurotology and serves on multiple editorial review boards of the fields of neurotology and otolaryngology. Providing more than 150 oral presentations, he has published more than 75 journal articles and has authored 34 book chapters. Again, it is a great honor to have Dr. Gianoli as part of the faculty of the CCVR course. We welcome Dr. Gianoli.
Hi guys, thanks for tuning into my video presentation. My name is Gerard Gianoli. I'm a physician specializing in neuro-otology and skull-base surgery in Covington, Louisiana, which is just outside of New Orleans. Over the course of my career, I have narrowed the focus of my practice to the point that now about 90% of my practice is vestibular imbalance disorder patients. My partner, Jim Swallow, and I have amassed every vestibular testing machine you can name, and some I bet you can't name. Because of this, we have seen more than our fair share of dizzy patients involved in litigation. This is a group that very few, if any, of my colleagues want to see for the following reasons. Number one, reimbursement is extremely low for evaluating dizzy patients who arguably are more complicated to evaluate than the vast majority of patients out there. In fact, my colleagues can make a lot more money seeing patients to remove wax out of their ear than evaluating dizzy patients. Two, when litigation is involved, our most useful and cost-effective tool is mitigated, the history. It is clouded by the specter of monetary gain. And lastly, the means to objectively identify who has pathology and who doesn't is also poorly reimbursed. Consequently, not many of my fellow neurotologists like to see these patients. However, in our practice, long ago, we opted out of all third-party payers such as Medicare and private insurance, and we charge a reasonable cash price for our services. And that is why we see more than our fair share of these folks. We can spend time with these folks to evaluate them thoroughly, test them extensively and objectively without going broke. Well, if you were ever called to be an expert witness involving these folks, the first question I would have you ask yourself is, who are you working for? As healthcare providers, we're often told we're an advocate of the patient, you know, and that is kind of ingrained in our brains as we go through training. However, you may have been hired by a lawyer, and whether he's from the defense or the plaintiff, and he's paying your bill. So are you a legal advocate? Well, the answer to both of these questions is neither. You are neither the patient's advocate nor a legal advocate. When you're working as an expert witness, you are an agent of the court. The purpose of you is to evaluate objectively and try to help the court identify the truth of the situation. So you're neither the patient advocate nor the legal advocate. And so consequently, this is a little different than what you typically are involved in with patients. Some basic principles we should go over when evaluating these patients who are involved in litigation. You want to extensively document their history and physical. In our office, we have a very large questionnaire. We have the patients fill out in their own handwriting. We have them sign it and date it. The reason we do that is so that if there's any question down the road when we're involved in a deposition or trial situation, it's not a he said, she said scenario. I can point to the questionnaire and say, this is what the patient said, this is their own handwriting. Secondly, you want to extensively test to objectify these complaints. You can't take the patient's word for it because they have the specter of monetary gain involved. In these times, everyone talks about being cost conscious. You don't want to order expensive tests. However, when the patient is involved in litigation, the testing that you do is more than likely the least expensive part of the entire process. When somebody's looking at a potential $1 million legal settlement, a couple $1,000s on testing is nothing. It's a drop in the bucket. You also need to assess all the pathology the patient has prior to settlement, because once the settlement occurs, that patient's not going to get any more money for their pathology. So if there's something there that you have not evaluated and left unresolved, the patient's stuck with it, if you would, and you haven't turned them a good deed. You also want to make sure all the pieces fit. Do the symptoms and severity correlate with the disorder? Do they have the appropriate physical findings for the history they give you and such? Next, dealing with lawyers. You know, what I have seen in my career is that for the most part, the vast majority of lawyers want just an honest appraisal, whether they're the defense lawyers or the plaintiff's lawyers. You can think of it like this: with a plaintiff attorney, when he has a patient, he's working with that patient and investing in that patient. He pays all the bills. If he puts a lot of money into a case, gets to trial, and he may put out $100,000 or more into a case, and later finds out the patient's been lying to him, he loses all that money. He would much rather find out early in the process what's going on, that the patient may not be honest with him. And some of the most thankful lawyers I've ever had are plaintiff attorneys where I've told them that they have a patient who's malingering. They thank me profusely, and because I probably have saved them tens of thousands, if not hundreds of thousands of dollars. The same goes for the defense side of the equation. They want to know what they're dealing with and whether they should litigate or just settle the case. Secondly, causation. The attorneys want to know, is the pathology you're seeing related to the incident that's being litigated, whether it's a car accident or fall or what have you? You need to know the definition of probable. That's a legal term. Probable is 50% or greater likelihood that the issue is involved, is the cause of the patient's pathology. When you say it's more probable than not, that's what the attorneys want to hear, or not more probable than not. They don't want you to say possible, because anything is possible. In fact, if an attorney ever asked me, is it possible, doctor, that such and such and such and such, my answer is always, anything's possible, but it's not probable. You don't need to be 100% certain. You only need to be more than 50% certain. Next, they want to know about prognosis. Is this going to be a lifelong disability, or is this going to be a short-term problem? And lastly, for your own sake, I would urge you to be paid in advance for these folks. I know that sounds very different compared to what we deal with on a regular basis with other folks, but there's two reasons for that. One is it's going to be much harder to get paid after the fact. You know, very often, once you've delivered the services of giving your expert opinion, you're low on their priority list to pay. Second, if you get paid after the fact, your opinion will be swayed by the specter of being paid, or at least that's the way it will be perceived. So if you're paid in advance, it doesn't matter what your opinion is. Whoever's paying you for it may not like your opinion, but it's too late. They've already paid for it. So you never want to get paid after the fact, because then it can be construed that your opinion will be swayed. And you will have office visits. You may need to produce a narrative. You may get called to be deposed or actually be witness in a trial. And I would tell you, for all of those, be paid in advance. In our office, we do not even schedule a patient for assessment until after the check is cleared. And that's from long years of experience with this. In the year 2000, we looked at 100 patients in two different groups. And these were folks that were having posterography performed. Half of them had some sort of legal status pending, such as litigation or work comp claims, et cetera. The other half had no obvious legal status or no obvious cause for potential secondary gain. Among those who had legal situations involved, 76% had non-organic sway patterns on posturography versus only 8% who did not have a legal status. And just so that we're clear, non-organic sway pattern means not physiologically possible. In other words, they are exaggerating or malingering their balance problem. Now that I've said that, there are other possibilities for non-organic sway patterns. You could have a technical problem with your equipment and it's malfunctioning. You could have a patient who didn't understand the instructions of testing. You can have a patient who's mentally incompetent and not capable of understanding the instructions. But when you have ruled out those things, pretty much the exaggeration or malingering are the answers that's most likely. I will also throw out there panic and anxiety disorder can cause some mild non-physiologic sway patterns, but these folks generally, once they settle down, will give you very good results. Also in that study, we found that among those patients that had legal status pending, there was roughly about 25% who had history, physical exam, and testing that all pretty much corroborated each other, identifying the quote-unquote honest group, about 25% of the folks. You had another 25% where they had completely non-physiologic results. We could not identify any objective pathology in these folks, and these were the folks that were very suspicious for being completely malingerers. However, you had another larger group, 50% roughly, of the patient population where we could identify some pathology, but there was also some non-physiologic results suggesting these patients were exaggerating. This was the symptom magnification group. Well, if you look at these three groups, you could say that 3/4 of these patients are either malingering or exaggerating. You could also look at this and say 3/4 have a balance problem, an objectively identified balance problem, and you would be correct in both cases. So the big thing is you have to figure out how much of this is honest and how much of this is exaggeration. Let's define malingering. This comes from W.F. Gorman. Malingering is the false and fraudulent simulation or exaggeration of disease performed in order to obtain money, drugs, evade duty or criminal responsibility, or other reasons readily understood from the individual's circumstances, rather than learning the individual psychology. And I think that's a very good definition of what malingering is. Now that said, malingering is actually one of the diagnoses found in the DSM-5. And if you look it up, you will find it's any combination of two of these criteria. The first is a medical legal context of presentation. For the purposes of our presentation, that's every single one of the patients with dizziness involved in litigation. So that, number one. So if they get any of the other three, they meet the criteria for the diagnosis of malingering. Second is marked discrepancy between subjective and objective findings, meaning the patient's got some real minimal findings, but real maximal complaints, if you would, or complaints of disability. Third is a lack of cooperation in testing or treatment, such as absolutely refusing to do testing or giving you non-physiologic results when testing, implying that they're not cooperating effectively. The last is antisocial personality disorder, which I never have made this diagnosis. I'll leave this up to our psychiatry and psychology professionals for this. But what I would tell you as far as the diagnosis of malingering, I would never make the diagnosis, but I will state whether the patient meets the criteria for this diagnosis. And I do that a fair amount if it is appropriate. We're going to go over a few cases to kind of explain and bring out some points involved with these litigating dizzy patients. The first one is a 31-year-old male who had been involved in a motor vehicle accident, complaining of dizziness and unilateral hearing loss afterwards. I put him through a very objective evaluation, found he had a unilateral high-frequency sensory neural hearing loss. he also had BPPV in that ear as well. And my report basically said this all fits, it seems appropriate. However, I noted in his history that he had been in the military, and because he was in the military, he would have gotten a hearing test when he was discharged from the military, and sometimes at admission as well. So I recommended that those records be obtained. Well, when I was deposed, the defense attorney brought out his old military records. And when he showed them to me, we found out that he had unilateral hearing loss and BPPV after some trauma involved in the military. And so consequently, it was unrelated to the motor vehicle accident. It had predated the motor vehicle accident. This is what you call malingering by imputation or malingering by false imputation. Basically, the patient has pathology, gets involved in some sort of episode, like they fall down in Walmart or whatever, and then claim that whatever pathology they had before is due to that fall in Walmart, and now they're suing Walmart. You can't assume that a patient has a normal premorbid status. So you need to get their old records or recommend someone look at their old records. And the most frequent place you can find, obviously medical records can be helpful, but also military records and industrial records can be helpful. Industrial records often have some sort of evaluation, both from the standpoint of auditory function and sometimes balance function. Case number 2. This is a 45-year-old female who had complaints of worsening of Meniere's disease and BPPV after a motor vehicle accident. She was seen should I say, she had 3 experts for the plaintiff who concurred that this lady, her Meniere's was worse because of her motor vehicle accident. She was sent to me for evaluation, and she gave us significant non-physiologic test results. So she fell into that category of 50% where she's got some pathology, but also significant non-physiologic test results. When I reviewed her old records, however, what I found was she had a vertigo a few days prior to the motor vehicle accident and did not have vertigo again for 2 months after the accident. Further, when you review the records, you find that prior to the accident, her vertigo problems were so bad that she had been referred for deafferentation, basically a labyrinthectomy or complete destruction of her inner ear because her problem was so bad, and she never got it done. Given how often she had vertigo before the motor vehicle accident, it could be argued that the motor vehicle accident actually made her vertigo better. And when I presented this at trial, basically 2 of the 3 plaintiff experts changed their mind and concurred with me. Consequently, the defense won this case. For whatever reason, one expert just did not want to change his mind no matter what. But this leads to another thing that I think you need to keep in mind. Be prepared to change your initial opinion as new evidence arises, because some of the evidence in individual cases will not be apparent to you. Like the case we mentioned earlier with the military records, once they showed me that this individual had been involved in trauma in the military, it became obvious that what the patient had told me was not entirely true. So you need to be able to change your mind as the new evidence arises. And that's quite fine because, you know, it's no shame to change your mind when new evidence arises. You also want to do a full objective evaluation of the patient. And what we found with these cases, the 3 prior plaintiffs had not done a full objective evaluation. They basically just saw the patient in the office and took the patient's word as given to them, which is not completely appropriate when dealing with patients who are litigating. A full record review will prevent embarrassment in the courtroom, is one of the lessons learned from this situation. So, you know, that is important to have the record review. Some red flags I would point out for you to keep in mind when these things happen. You need to increase your index of suspicion for someone who may be malingering. First of all, if they are unable to or refuse to complete testing. I've been doing vestibular testing for 25 plus years, and it's very few patients outside of the litigating population that cannot perform testing or are unable to perform testing. Second, if the symptoms seem too severe for the objective findings you're seeing, you need to have some suspicion about malingering. Third is lots of falls. This is something that may not seem obvious to people not involved in taking care of balance patients, but you know, when someone comes in, they've had lots of falls, you have to ask yourself why. Maybe one fall you can understand, but after that, for the most part, most people don't like to fall. They become more cautious in their habits. They put out their hands to prevent injuries. So if they have lots of falls, you have to be somewhat suspicious. I'll relate to you one particular patient who was sent to me by an attorney. When I walked into the exam room, he looked like he had been in a fight. He had black and blue marks all over his face, and he actually had a laceration on his forehead that was actively bleeding. I asked the gentleman, you know, were you in a fight or a motor vehicle accident? He said, oh, no. I've got all these injuries because I'm so dizzy, I'm fall and I hit my head, and I just fell in the bathroom right before I came in to see you, and that's why I've got this cut on my forehead. Well, when this guy was fully evaluated, all of his tests were very non-physiologic, which, if anything, demonstrated he had actually very good balance. And he eventually admitted that he was self-mutilating because of the specter of the couple $1 million lawsuit he had filed. And that pretty much killed his lawsuit. Non-physiologic test results. Romberg testing, keep in mind, Romberg testing is a test of proprioception or posterior column function. It is not a test of vestibular function. Unless someone is in an active vertigo spell, they should have a normal Romberg test, even with very bad vestibular function. So right off the bat, if someone fails the Romberg, you got to think, well, either they've got a proprioceptive issue or they're trying to pull one over on you. Secondly is the Fukuda test, and I'll show you a video demonstration of the Fukuda test for those not familiar with it. But the Fukuda test, the patient is asked to walk in place for 30 seconds with their eyes closed. One big tip off is the Fukuda test. That's not physiologically pulled, and that's one that I've picked up just on some medical record reviews of folks. Next is audiometry. For the most part, if you have a good audiologist, they can detect when someone's trying to feign a hearing loss, and that's another big red flag, obviously. If you have access to posturography, there are published patterns, and we've published on this as well, for non-physiologic sway patterns that are very suggestive of malingering. We've also used the MSPQ, which stands for the Modified Somatic Perception Questionnaire. This is a checklist form that the patient can fill out very quickly, and it will identify patients who are suspect for malingering. This was originally used in pain patients, but we correlated it with non-physiologic sway patterns on posturography and found it to be very useful in identifying patients who are feigning a balance problem as well. Anytime the patients have behavior inconsistencies such as lies, exaggeration, or poor cooperation, those should be big red flags. And lastly, when their balance problem fails to be diagnosed as a particular diagnosis, if it's an uncertain etiology of their dizziness, it doesn't mean that they are malingering, but you have to kind of put that in the back of your mind as a possibility as well. Now, this is one of my former employees who had a left-sided vestibulopathy, and she's doing the Fukuda test here. She's got her eyes blinded, and she's walking in place. And as you'll see, over the course of about 30 seconds, she will rotate to the left side. This is a pathologic Fukuda test, a left-sided vestibulopathy. The normal result is if there's no vestibulopathy. The patient either walks in place or slowly moves forward. But in this case, that's an abnormal left Fukuda test. In this next video, I asked her to fake like you're dizzy. I want you to try to convince me you have a dizzy problem. And I kind of told her the whole scenario is if you got a lawsuit pending, et cetera. And she did such a good job that I kept this video because it's a great demonstration of what people do when they've got litigation pending and they're trying to fake a dizzy problem. And you'll see they bounce from side to side. They almost fall, but they never do. And she did it so well. This is just classic. Almost fall, but not quite. And she'll keep going and almost fall, but not quite. But this is non-physiologically completely. This is not something you see with a vestibular disorder. Case number 3. We have a 51-year-old male with right-sided sudden hearing loss and vertigo after a loud beep was heard on his cell phone. He was seen by a physician who became the plaintiff expert who agreed with the patient that the cell phone caused his sudden hearing loss and vertigo. Problem is, the cell phone in question has a maximum output of 105 decibels, okay? That is inconsistent with something that could cause injury and the problem the patient reports. I can tell you as a neuro-otologist in my testing lab, we put more than 105 decibels in patients' ears every day, all day long for the last 25 plus years, never caused a problem. In fact, OSHA does not require hearing protection for a couple moments of 105 decibels in the ear. This just makes no sense from a physiologic standpoint. Also, too, the plaintiff expert did not exclude other causes for this patient's hearing loss. And from an auditory standpoint, the guy was a frequent gun advocate who would hunt, and the noise from a shotgun is in excess of 140 decibels sometimes. And there's the non-acoustic concussive blast that can cause injuries to the ear that is much worse than a cell phone. He was also someone who would go to LSU football games, which have been measured in the 130 to 140 decibel range. So for him to say that a beep heard on his cell phone for a second caused these problems just doesn't make a whole lot of sense. He also failed to get imaging, and when we got imaging, we found the patient had an acoustic neuroma on that side as well. So that's more than likely the cause of his hearing loss and dizziness, not a beep on his cell phone. Don't forget imaging and to look for other causes of symptoms. This is very important. Again, you need to make sure the mechanism of injury is appropriate for the pathology you're finding. And do not take the patient's word for the mechanism of injury. That's inappropriate. You need to figure that out for yourself. Remember, the patient's got monetary incentive for you to take their word. And here we have a CT scan demonstrating an arachnoid granulation eroding into the posterior aspect of the temporal bone, causing labyrinthine dehiscence, and this can cause vertigo, dizziness, and balance problems. Case number 4, this is a 50-year-old medical instrument salesman with chronic disequilibrium that's worse in the dark. He was 3 years post-op from a left acoustic neuroma resection through a retrosigmoid approach, and he had a disability lawsuit pending. He was sent to me for evaluation. On his physical exam was essentially normal except for his Fukuda test, which was very non-physiologic. It was very suggestive of that video we just showed earlier that my tech had done for us. On his ENG, he had 100% caloric weakness on the left side, which is what you'd expect after acoustic neuroma resection. He also did not have any spontaneous nystagmus. And when you see someone who's had 100% caloric weakness and has no spontaneous nystagmus, it begs the question as to whether this has been compensated and suggests that he may already have his vestibular problem mostly resolved. Audiometry showed hearing loss on that side, as would be expected from an acoustic neuroma resection. And his rotational studies did show his vestibulopathy was uncompensated, but very minimally. He was almost completely compensated. His posturography was also instructive. I don't know how often you guys are familiar or seeing posturography results, but what he gave me was normal results on conditions 1, 2, 3, and 4, and abnormal results on conditions 5 and 6. Now, those are the conditions where you will see vestibular test abnormalities. And if you look at the sensory analysis, he comes up with a very poor vestibular test profile. So if you just look at these two outputs, you'd say that looks physiologic and suggestive that this guy's got a bad vestibular problem. However, if you look at a strategy analysis, he's all over the place. Ankle dominant, hip dominant, his center of gravity alignment's way off. So something's a little funky here. So let's look at some of the raw data involved in this particular case. And if we look at, let's just remember when we're evaluating someone on posturography, we're measuring their center of gravity according to the sensors in the floor. And there is this invisible cone around the patient. And if that patient's center of gravity were to fall out of the cone, they should fall, whether going forward, backwards, side to side. And that is something that this patient did not do. If you look at the raw data for conditions 4, 5, and 6, on conditions 5 and 6, he's got a couple of falls, but this fall, he's so far out of his cone of balance, and if you would, these red circles are roughly the cone of balance, he's swinging in and out of it so much, and he's actually showing us he has very good balance, not bad balance. And this is what you see in someone who is a very educated malingerer. Well, the outcome, he's filed his lawsuit for disability. About 6 months after he filed the lawsuit, he opened up a business basically selling equipment and doing the same thing he was doing before. When I explained how he was malingering on the posturography, he claimed that my vestibular technician was pushing him during the test. Well, that's interesting, we said. It turns out we videotape all of our testing. And let's pull the videotape. This is back when we had actual VHS videotapes. Why don't we show that and see if the tech is pushing you? And of course, the tech was not pushing him, so that did not fly well with the lawyers. He could not find a medical expert to corroborate his disability. So consequently, this particular individual settled. And the way the insurance company settled with him is they said, okay, you can keep the money we've given you already for the last 3 years, but you're not getting anything more after this. And in fact, they could have sued him for fraud in this case, but they didn't. Well, a few months later, I get a call from another attorney on this case. And it turns out this patient is suing his lawyer for legal malpractice. He's suing his own lawyer because his lawyer could not get a medical expert to contradict what I said. In my phone conversation with this new lawyer, he tells me, well, at this point, because he's suing his own lawyer, there's no more lawyer-client privilege, and the lawyer who is now the client of this new lawyer can tell us everything that the patient said. And basically what the patient said is, I've worked with neurotologists and balance professionals, and I know how to fake these tests. And my response is, well, great. All you have to do is say that and you win the case. The lawyer then reminds me on the phone and says, no. I can't do that, because can you imagine me going in front of a court and saying my client, the lawyer, was representing a patient who he knew was faking? We will lose, and he will lose his law license. So consequently, we have to settle this case too. So this particular patient feigned a dizzy problem and got a settlement, not just from the disability company, but also got some of the hide out of his own lawyer. So this can be a pretty sticky issue, if you would. Well, what do we learn from this? These cases may linger and come back even when you think they're gone. I will tell you, there was another case I was involved with. I was an intern in general surgery. This is the year 1987. When I was driving home, there was this horrific accident. Someone drove their car into one of these big concrete pillars that hold up a railroad crossing. And he had a big laceration across his neck, he had compromised airway. So I stayed and helped maintain his airway and get him to the hospital. I went and visited him in the emergency room at in the ICU at Charity Hospital the next day just to make sure he was okay. And that was completely my involvement with it. Well, about 15 years later, I get a notice that I'm going to be deposed on that case. And I thought to myself, what the heck is going on here? So I call his attorney and I'm like, why is this coming back 15 years later? And he said, well, it's because he was in jail for 10 or so of the last 15 years. And I said, oh, that's interesting. Now he's suing the city for putting that concrete pillar on the side of the road that he ran into. I thought that's interesting. Well, it turns out I never did get deposed. And apparently he must have dropped the suit or it got settled, one or the other. But about another, maybe 10 years after that, I get a phone call from the patient. And I answer the phone and he informs me who he is and says, look, I just want to thank you for stopping and helping and saving my life that night. I was in a bad place at the time. I spent some time in jail, but I've turned my life around and I have a wife now and two beautiful daughters. And I have at least in part you to thank for that, for saving my life. So even though it turned out good, it's one of those stories where the litigation can happen many years after the fact. Repeat lawsuits are not uncommon for this crowd, so you have to protect yourself when you're dealing with these folks as well. Document everything. Case number 5. This is a case of a patient who was dizzy after getting gentamicin therapy for osteomyelitis. And he then filed a lawsuit with an attorney. He was seen and had testing with calorics that showed bilateral caloric weakness. And the argument was this guy had his vestibular system ablated with gentamicin, and he's now a vestibular cripple as a result of that. However, they never did rotational studies on this particular patient, and he was sent to me by the plaintiff. When I spoke with this guy, I found out that nobody wanted to treat him or evaluate him once his legal status was known. As I mentioned, my colleagues are not crazy about taking care of dizzy patients, but they really don't want to take care of dizzy patients who have litigation pending. And this guy was in that boat for sure. Well, once we evaluated him, we found he actually had normal calorics and normal rotational studies. So the gentamicin did not ablate his vestibular system. He had bilateral abnormal Hallpike testing. And when you talk to this guy and ask him what sort of problems he has, he talks about positionally induced vertigo and disequilibrium. Once we treated him with canalith repositioning, his symptoms completely resolved and he dropped his lawsuit. So what do we learn from that? Do not rely on other people's evaluations. You want to do your own evaluation. Sometimes the other evaluations may have been done haphazardly. Sometimes they were done not knowing what's going on with the patient, and maybe the patient's input was not as it should have been. Some patients with potential for secondary gain are actually more interested in the resolution of their problems than the monetary reward, and that was the case for this particular guy. He was mad that he was dizzy. He was mad at the doctors because he thought the doctors caused his dizziness, not realizing that was not the case. And once his balance problem was resolved, he was an extremely happy guy. Case number 6, this is the normal evaluation case. This is a patient who comes in, he's got a plausible history for a vertigo, dizziness, balance problem. He's cooperative, or he or she is cooperative and compliant. They have a normal physical exam. They have normal audiometry. They have normal vestibular studies, and they have normal imaging. Well, what do you do with this person? What can we say about them? Well, what I would tell you is vestibular testing is much more specific than sensitive. The positive predictive value of vestibular testing is much greater than the negative predictive value. In other words, if it's normal, it doesn't mean they don't have a balance problem. Keep in mind, even though vestibular testing has dramatically improved over the last several decades, there's still a lot of the vestibular system that we are just basically scratching the surface. So when I have someone who comes up with a normal test battery and they're cooperative and they don't give me any non-physiologic results, I tend to believe that this person probably has a problem that we can't adequately assess. Consider benign positional vertigo. Benign positional vertigo, as you know, is probably the most common cause of vertigo and dizziness we see. It also has the property of fatigability, such that these folks can come in, you can do your Hall pikes or whatever kind of positional testing you want, and it may be normal because the result has been fatigued out from their head maneuvers on that day. I would tell you, consider repeat evaluation of this patient on a different date. That's probably the best you can do in those cases. But you can't say they're malingering, because they're not. All you can say is you got a normal evaluation and they may have something that we can't pick up on testing. Assumptions. Your work will be reviewed by others. So when you're seeing these folks, keep in mind that other experts are going to look at what you've documented, what you've done. So keep that in the back of your mind. Secondly, financial incentives obscure the picture. That's one common theme throughout all of this. I will tell you another scenario that is probably harder on clinicians than any is when you have someone who is currently a patient of yours and they come in after a motor vehicle accident or some trauma, and they've got some pathology and they're being very honest and cooperative with you. As they get involved in the litigation system, some of these folks, the picture will change. Their history will change. The pathology they describe to you will change. It'll be worse. They'll start having some non-physiologic test results, et cetera. So keep that in mind. Even though they may have been very honest and cooperative with you initially, some of these folks later down the road will change because of these financial incentives. Remember, repeat lawsuits are not unusual, like the case we went through earlier. And you will oftentimes be deposed or actually asked to be testify in trial. So don't be surprised with that. Never assume any prior diagnosis is correct. Always come up with your own diagnosis. As I mentioned, the prior clinicians may not have been aware of some of the factors that you're aware of and be able to change your opinion as the evidence arises. Neuropsychological referral is very helpful for some of these folks. Very often there's some cognitive complaints associated with these dizzy folks, especially if they had a head injury or concussion. And our neuropsychological colleagues are very adept at testing and identifying pathology and also malingering. Documentation, you want to document extensively the history, your physical, and any testing you do in these folks. And remember, it will be reviewed later by others. You need to objectively validate the symptoms. You can't take the patient's word for it. You have to demonstrate it objectively. As we mentioned, your technician is, or audiologist, whoever's working with you, needs to be on the same page and aware of these particular constraints involved with these folks. If you're going to deal with these patients that are involved in litigation, everybody in your office has to be on the same page. You also want to make sure your equipment is calibrated, because if your equipment is not calibrated and that comes out in later testimony, that's going to shed shade on all of your testimony. can you rely on your equipment will be questioned. And remember the financial considerations, both on the patient standpoint, but also for yourself. If you're going to be involved in this, it is time consuming, it can be frustrating, so you want to make sure that you receive monetary recompense for it. And that is all I have for you on the evaluation of dizzy patients involved in litigation.